Hello everyone and welcome back to what is the final session of this live streamed respiratory therapy update teaching day. And what a day it's been. I'm so grateful to all the speakers, but incredibly grateful for these next two really important points for looking after patients in general, especially respiratory patients, post-critical care patients, but also during a pandemic. So I'm delighted to introduce Cath, who's going to go first, followed by Charlotte. And Cath is an amazing respiratory physio who's now working in an advanced specialist practitioner role. And I used to work with Cath up in Lancashire, and she's amazing. So Cath, over to you.
Thank you, Rachel, and it's lovely to be part of the day. So thanks for the invitation. I'm going to talk to you all today about discharge planning for COVID-19 patients from hospital and really just give you some information about what to expect and what to be aware of when we're discharging our patients at the moment. So we've all seen the fabulous pictures and the patient stories in the media, in the newspapers and on television about patients that have had COVID-19 and being discharged from hospital. What an absolute joy that is for them and for us as well as their healthcare professionals. So it's absolute privilege to be a therapist involved in that part of the patient's journey, because obviously sometimes, quite sadly, that doesn't always happen. And there can be difficulties along the way in getting patients to this point, but it is absolutely joyful when we get pictures like this and we see patients returning and returning to their loved ones, returning home, recovering from COVID-19. So even prior to COVID-19, really the discharge to assess model was in place. And that's because we know as healthcare professionals that there is evidence that shows that if patients stay in hospital unnecessarily, then that can cause them harm. So the discharge to assess model really has been in place for a good few years now. And through campaigns such as the last 1,000 days, valuing patients' time and NPJ paralysis, we've been able to promote this discharge process within our hospitals. So really this model is about a proportionate assessment of the patient within the hospital setting and really preparing the patient to leave hospital as soon as they no longer require acute care. And the default pathway is home first. We're really aiming to get these patients in the first instance back to their own homes. What discharge to assess isn't about sending people home before they're medically ready or while they've still got ongoing clinical problems. And it's really about making sure that we provide that assessment for patient safety to determine what their ongoing needs, therapy needs, rehabilitation needs, and social needs are before going home. There are some different names that you might know it as. You might know it as hospital at home, you might know it as home first, and different things like that, reablement sometimes. So just being aware of what is that model in your local hospital and your local pathways and being familiar with that and the teams that provide it. So the discharge to assess model, these are the pathways that patients can be discharged on. And really the majority of patients, sort of 95% of patients, should be able to go straight home without any needs. Or perhaps 45% of patients will require some sort of rehabilitation or reablement package at home. But there really is only a small minority of people that will require rehabilitation in a bedded setting, so such as residential rehab, and again an even smaller percentage of patients that will require perhaps long-term or short-term residential care because they've been through a life-changing event and really home isn't an option for them at that stage. So that's what the model looks like. And these are the questions that we might ask ourselves as an MDT to consider if a patient is ready for discharge. So what sort of level of care are they receiving at the moment? Can that be provided in a community setting within their own home through community teams? And what's the value for the person going home? What needs to happen for them to get home? If they're not going home today, why is that? And what processes or actions do we need to take to make that happen? And really thinking about what that expected date of discharge is. So on the ward that we work on, this sort of discussion will happen in the board round on a daily basis, sometimes even twice a day, to really make sure we're progressing that patient towards discharge. And actually, the discharge assessment really begins at the very beginning of the patient's journey when they're admitted to hospital. So already at that point, we will be thinking about what the patient's home environment is like and what is likely to be the patient needs, what sort of pathway do we predict that they'll be able to go on. So it is a person-centred approach, looking at that individual and really doing that as an MDT. So I certainly work quite closely with our occupational therapy colleagues in the hospital to complete this discharge assessment, as well as our discharge coordinators and discharge teams. So really thinking about how do we mitigate the risk for discharge and of going home, and communicating that with the patient, with their family, with their carers, and getting information about what is likely to happen or what is likely for the patient to need. So the discharge assessment can cover all aspects, and it's the usual discharge assessment that you would do for any patient in terms of COVID-19. It doesn't particularly change, it's just being aware of what their needs are. And like I said, really from COVID-19 perspective, it has really enhanced the utilisation and implementation of discharge to assess models. So looking at the patient's mobility and thinking about how can they transfer, what is their, do they need any walking aids, things like that, what is their muscle strength like, is there any evidence of neurological deficit that we need to address and think about. And obviously a big one in COVID-19 is about the respiratory needs. And I know we've heard a lot today about treatment strategies and management of things like shortness of breath and sputum retention. So thinking about and identifying what those needs are at the point of discharge and putting treatment strategies or plans in place for the patient to manage, or referring on if that's needed. The other thing that we also screen for as well from the acute ward is thinking about breathing pattern disorders, which is something that we're seeing not all the time, but certainly more commonly with the COVID-19 patients, particularly if they have been on CPAP or have been proned, then we are seeing perhaps some abnormal breathing patterns that we're screening and picking up at that point of discharge or in the acute setting, and then thinking about how do we refer that on and follow that up for further assessment. Thinking about the patient's function, so do they have stairs at home? What's the home environment like? Do they need any assistive equipment? And also really thinking about nutritional status and social needs. So it's that holistic assessment and trying to identify what those needs are for the patient at that point of discharge. So we thought, like we said, we've heard a lot about managing symptoms today, and it's important to acknowledge the individual stages of recovery of the patient and provide treatment strategies as appropriate. So if it is a shortness of breath issue, providing treatment strategies for that, or ACBT for sputum clearance. So really just educating the patient about what they need to manage. But I really quite like this 6Ps model for more energy, because although it's about energy conservation, I think it really does sort of underpin all treatment strategies and how we can address these for COVID-19 patients. We're seeing a lot of patients, COVID-19 patients, going home with ongoing shortness of breath, fatigue, deconditioning, nutritional risk. So this sort of model you might want to think about helps to educate patients about how to manage things. So it's really about prioritising what tasks they need to do, planning those tasks and breaking them down into manageable things, manageable chunks. Think about the positioning when they're performing a task. So that not only so how are they going to do it, but what posture they're in. Pacing the task so that it is achievable, being positive about what they can achieve and realistic about that. Perhaps using strategies like pursed lip breathing to help control the breathing and manage the shortness of breath as they're performing that activity. So in terms of discharge criteria for COVID-19 patients, we really need to think about the existing capacity of the healthcare system. And really that discharge to assess model is there to help promote capacity and meet the capacity and demand needs, particularly as we're working through a third surge at the moment, and to promote a patient flow. So we're also thinking about what laboratory diagnostic resources are available at the time. And like I said, the current pandemic situation that we're working in, that does affect sort of the discharge process and perhaps some of the pressure towards discharge. But in terms of clinical criteria, what we're looking for really, like I said, we wouldn't be discharging any patient that isn't clinically well. And what that means is we're looking for the clinical resolution of symptoms. So that means an absence of fever for at least 3 days and an improvement in their clinical symptoms other than fever. So generally the patient is feeling better and starting to get better. We'd also be thinking about the time elapsed since onset of symptoms and about the patient's severity of disease. So, it can be different depending on the patient's journey and whether they've been in ICU or required respiratory support such as CPAP or NIV. And also considering the patient's immune status and whether they're immunocompromised. So we are able to look at evidence of viral load and whether that there is clearance of that in the upper respiratory tract, but it wouldn't necessarily be an absolute criteria for discharge. It's just something to be aware of in terms of the patient's viral load and does that have an impact on your clinical decision making about discharge. Okay, so being declared medically fit for discharge is a medical decision by the medical team. It isn't something that necessarily as a physiotherapist you'd be expected to do, of course, but it's just being aware of what that criteria is of why the consultant or the team will be making that decision. So the COVID-19 diagnosis will be stated on the patient's hospital discharge summary. And the patient should be provided with a leaflet about their discharge and provided with that information, including contact details of how to get in touch if they do experience any further problems. So quite often the local ward number will be on that information, or sort of local social service hubs numbers in case they find that they're struggling more than they expected once they get home, and also NHS 111 information. So like I said, the criteria of viral load clearance isn't an absolute criteria for discharge, but it's just worth knowing what that might look like. So patients do go home that are still COVID positive, that do have ongoing symptoms, but this is just giving you the criteria for what would be determined as viral clearance. And it would be at least 2 upper respiratory tract samples or swabs that are negative, ideally within a 24-hour time frame. Patients who are symptomatic, so for patients who are symptomatic after the resolution of symptoms, samples should be collected at least 7 days after the onset of symptoms or at the 3-day stage without fever. And for asymptomatic infected persons, the test to document viral clearance should be taken at a minimum of 14 days after that initial positive test. And that's just because we know we can still have ongoing viral presence if we start swabbing too much or too early. So there has been some controversy over the pandemic, the whole pandemic, about discharging to care homes. And the new requirement for the government now is that any patient that is discharged to a care home, they should receive a COVID swab test results 48 hours prior to being discharged. So that's obviously just something to be aware of within the discharge process. If that test result does come back positive, it doesn't mean to say that the patient has to stay in hospital, but it just means that they have to be discharged into what's being called a designated setting. And that designated setting can be within the care home if that's possible. It could be an isolation area or a cohorted area within the care home. But if that isn't able to be met, then there would normally be discussion with the local authority services to decide how we can best manage that patient. Sometimes they might stay in hospital, but again, that depends on the overall situation of demand and capacity and flow and things like that. So there'll be discussions about how we can best manage that patient who if they do need to return to a care home and they're still positive. We need to be a bit careful here though, because there does need to be some clinical judgment involved, especially if you're thinking about severe immunocompromised patients, and they might be exempt from this sort of testing if they have already completed the isolation period of 14 days within hospital and they're within that time frame of period onset. So there is some sort of clinical judgment, and that should be discussed or made by the medical team really. So it's really important that when patients are discharged that they are aware of their isolation advice, because it depends where they're up to in their journey of COVID as to whether they're going to still need to isolate when they get home. So we know particularly at the moment with the new variant, there's an increased degree of community transmission. The exact duration of infectivity of COVID-19 isn't completely known yet with any certainty. And so this advice of isolation is based on the limited evidence that we have to date. So if patients are discharged home earlier than 10 days from onset of symptoms, then they should be advised to isolate for that full 10 days. And that's particularly if they're a mild to moderate patient. So that might be a patient who has no or very mild symptoms of coronavirus, or it might be that they've had really limited oxygen requirements, so sort of less than 28%, and that they've got good prognostic indicators. If a patient is classed as severe, that would be a patient who has high oxygen requirements. Perhaps they've been on ITU and they've needed CPAP or care, or they've been proned, or they've got quite abnormal prognostic indicators, or they've got quite abnormal radiology signs and symptoms. So those patients, you might advise a longer isolation period of 14 to 20 days. So again, it just depends on the patient, but certainly I think a lot of patients do, sometimes they get the news they can go home and they're well enough for discharge, but you just have to reinforce this advice, because I think sometimes, particularly if they haven't seen loved ones and family for some time, perhaps they have been quite poorly, it's just their expectation is that they can see family straight away, and obviously they want to celebrate the fact that they're home, but it just needs to be, they need to be aware of this isolation advice really, and that should be given in a written form to patients at the point of discharge. So in terms of patient experience of discharge, so mostly they're all very, in my experience, they're really keen to go home and they want to avoid the risk of further infection. But quite often they do feel anxious and worried about discharge. And it's just providing them advice with being able to acknowledge this themselves. So if they're feeling anxious, it might be that they're having sleeping difficulties, that they're feeling shaky, have a racing heart, that they're struggling with the breathing control. And it's just offering reassurance and advice on how to manage these feelings. A lot of patients need to sort of understand what's happened to them, particularly if they are post-ICU. Perhaps they've had some episodes of delirium, but they're not always sure exactly what's happened while they've been in hospital, and therefore that can make them quite anxious about what to expect when they get home and how they're going to manage moving forwards. So really explaining to them what's happened throughout their hospital journey, and giving them some expectations about what's going to happen next, what follow-up they're going to have, and what any future care needs. So it's that education, it's that communication, which is really vital in supporting patients so that they have a good experience or as best experience as they can of leaving hospital and knowing what to expect. So when patients do leave hospital, we do give them safety netting advice, and that's really again so that they know or look out for any problems, or know how to deal, if any problems arise, know how to deal with that and know who to contact. We know in the course of COVID-19 that there are certain time points that can be critical. And so patients might be discharged, day 1, day 2 after symptoms. And it's just giving them that safety netting advice of what to watch out for. We know in COVID-19 that around that day 5 to 7 that patients can present with silent hypoxia, or that they can have difficulties with their breathing and deteriorate at that around day 10 stage. So it's just for patients to be aware of that, what to look out for and how to address that if they need to. Most patients do tend to recover within that 10 to 14 day time period, but it's just so they're aware of that safety netting advice in case problems arise. So these are some of the information we would give to patients about when to seek medical advice. And particularly if we're thinking about the thromboembolic nature of COVID-19 and the risk of PE, severe breathlessness is a key thing to be educating patients about. And when we say severe breathlessness to a patient, that might mean that if they're unable to complete sentences, if they have a rapid or a significant deterioration in their breathing in the last hour, if they have any new breathlessness at rest that's different, or any sudden onset of breathlessness, they'd be key things or red flags what we'd be saying to the patient to think about contacting medical advice. We tend to not always say, depending on the time frame after discharge, we tend to not always say speak to your GP, because we know how overworked our community colleagues are and what the demand on them is. It might be you would be saying contact the ward, or you'd be saying utilise NHS 111 online. So also looking at for signs and symptoms of shock or sepsis, thinking about new confusion, any reduced loss of consciousness, if there's any change in their temperature, such as being really cold and clammy, and thinking about the urine output and any skin colour changes. So they're just tips for patients to be looking out for. The other one as well that is quite significant is if the patient or family feels that they have any functional impairment. So if they suddenly have a change in their ability to look after themselves or perform activities of daily living, then they should be asking for advice regarding that. So more recently, and particularly over the last couple of weeks, I guess, the sort of questions that patients are asking about discharge is sort of vaccination information. They're really keen to understand what the vaccine is and when they're going to get it and what their priority is for receiving the vaccine. Obviously, we're finding out information about that all the time at the moment with the new vaccines coming out and where we're with that processes. And patients are quite often asked about research trials, how they can get involved, how they can donate their plasma. So it's just understanding where to direct those sort of queries to within your local area. I think thinking about culture as well and cultural considerations, our patients going home to multiple generation households, how does that affect their ability to isolate? How does that affect their ability to manage and recover at home? And a lot of questions around returning to work and financial considerations. So if people do need to isolate, they can now download isolation notes. So rather than sick notes through the GP, they can access isolation notes through NHS 111 online. So that's a good resource to signpost people to if needed. So as we've mentioned a little bit about the risk of hypoxia in COVID and monitoring that, a lot of services now are offering COVID oximetry at home. And in fact, this has been mandated by many CCGs for providers to implement. So this can be in the community setting. So it can be patients who are managed in the community, but also certainly in our hospital where we have access to step down into the COVID oximetry at home service. So these are just really vital services to know about in your area that you can reassure the patient about if that's appropriate for them. The criteria for COVID oximetry at home is generally that a patient has to be COVID positive and they have to be symptomatic. And most services are providing this for patients over the age of 65. If a patient is under 65, then they can still be considered. It's based on clinical judgment and whether that patient might be clinically extremely vulnerable. That would be another consideration. So this is just the local pathway that we have for stepping down into COVID, in the COVID oximetry at home service. And actually in a lot of areas, as well as in Preston, it's been a real triumph to get these services up and running really quite so quickly. And I know there's been a lot of work done nationally throughout the country in different regions to get these services up and running. So in our local area, the service is actually provided by Go2Doc, which is a private out-of-hours GP service provider, like a social enterprise really. So we can refer into them to follow that patient up, and they will provide the pulse oximeter for the patient, provide education of how to use it, and provide that telephone support and monitoring service. If the patient becomes unwell on that service, then there are pathways to set them back up into the medical assessment units or into ED. And again, these patients can be referred into that for monitoring from ED. We've been quite successful with a few cases who've been managed in that way. So I think, I know Charlotte, who's coming on after me, is going to talk about long COVID and follow-up, but a lot of patients are being followed up now. We've got a lot of COVID follow-up pathways in place. This is the team that I work with. We're providing a virtual follow-up service. Some of the personnel has changed now from that picture there, but generally what it illustrates is that it is an MDT approach. So we have physiotherapists, specialist nurses, medical teams. We've had speech and language supporters as well. And really what we're providing is that telephone review within 2 weeks of discharge ideally. Sometimes depending on staffing, it has got a little bit longer in our case, but really we're providing that telephone triage follow-up to see how the patient is getting on, to provide ongoing advice about symptom management, and to signpost onto other services as required, such as we've done a lot of referrals into our local frailty team, and also to arrange further follow-up, whether that needs to be face-to-face in clinic, assess rehab needs, and think about ongoing investigations if that's needed. And really, in my experience, patients find this really reassuring. They're really grateful to know they've got a point of contact and they've got somebody who's perhaps going to be watching out and following them up. And we're just doing this at the moment for the patients from hospital. And again, that's where COVID oximetry, there's a little bit of overlap, there's a little bit of working together and collaboration, but it is generally working really quite well. And what we've developed at Lancashire Teaching Hospitals is we recognised during the first wave of the pandemic, actually back in April 2020, that patients were likely to be discharged at an early part in their recovery process. And therefore, because at that time COVID was quite a novel disease and we didn't know an awful lot about it, we wanted to provide some information that the patients and carers could access to help manage them in that journey. So we developed a multimedia web-based resource for patients and their families, which is available on all digital platforms and provides information and guidance to support support the patient in the self-management as they begin their recovery journey. And this resource at Lancashire Teaching Hospitals was developed by a multidisciplinary team with expertise across a range of areas to bring that information together and apply it to what we knew at the time about COVID-19. And actually, it's been really successful. There is the NHS Your COVID Recovery resource available as well, but this is what we're using at a local level, and this was launched in April of last year. So we've had quite a lot of feedback about the resource. This is how you can access it with the QR code and the link at the bottom. It covers a wide range of things, like I said, because it is being developed by an MDT. So things like nutritional advice, how to manage breathing and shortness of breath, how to help expectorate phlegm, mobility, exercise. And then we've really updated it quite a few number of times since it was launched regarding information as it's become more apparent and as we've learned more about COVID-19. So things like a little bit about long COVID, returning to work and things like that. So it has been accessed in over 86 countries and by 77,000 users. So it has been quite well resourced, and the feedback we've received has been really positive on the whole. And that's what we've used to try and update the resource and sort of make sure it's up to date and relevant. I think the last thing I just wanted to sort of mention was that across the whole of managing COVID patients and, including discharge planning and the discharge process, it can feel quite overwhelming at times, particularly as a therapist. You're working on the ward, you're finding out this patient's medically fit for discharge, you need to do the discharge assessment, you need to speak to the patient, speak to the family. So it can be quite overwhelming, it can be quite intensive, and there's a lot of competing things for your attention or competing demands that you're having to deal with. And I think it's just being mindful of the fact that the discharge process has changed. We are working in a pandemic, so it makes it a little bit more difficult. We're not perhaps able to provide the patient with an absolute perfect discharge or perfect care. And it's about, as a therapist, being able to embrace that risk, being able to mitigate those risks as much as possible, but just being realistic yourself about what you can provide, and obviously just doing your best, but acknowledging that doing your best sometimes isn't always going to be perfect. Discharge process is an MDT approach, so it isn't just down to one person's responsibility, but it's working within that team and collaborating to do the actual best for your patient. And then you get those lovely pictures of patients going home and being able to celebrate recovering from COVID-19 and getting back to their loved ones.
Thank you so much, Cath. Incredible as always. There is a few comments in the chat. I'm trying to condense them, but discharge with oxygen, that's been something obviously that we've had to do more than ever. Have you got any tips on the types of patients that should be discharged on oxygen, or the types of patients that we should be keeping in the hospital to wean completely?
Yeah, I think it very much comes down to an individual patient risk assessment there. So you need to really understand what the patient's respiratory history is, if they do have any diagnosis of for example, COPD. And actually, what we're finding at Lancashire Teaching Hospitals is we're not discharging as many patients as we expected. There's definitely more than there was with acute hypoxia, but there's not a massive cohort that we expected. And I think that's because we are just making sure that patient is clinically as stable as possible before discharge. And that's where the COVID oximetry support service has been really helpful. It gives you that bit more confidence. If somebody is still a little bit hypoxic, do you need to just give them a little bit more time to recover? Is there still some reversibility there? And then you've got that monitoring service to support. And if they are needing to go home on oxygen, it's just making sure that they've got that good home oxygen support service, follow up as well by the oxygen delivery teams.
For some, it's I think you covered it in the whole presentation, but it's a thorough assessment before discharge. And if I'm being totally honest, we'll talk about an ideal model, and in pandemic times, for those of that are in surge and super surge, sometimes that is just impossible, isn't it?
And I think that's just where your safety netting comes into play there, even more so than ever.
Exactly. And it's just maybe making sure, if desaturations happen, if the patient's compromised, because that physiologically we can't discharge people home with significantly no oxygen levels, and by that I would mean anything, if in a fit, normal, healthy person, that would be in below 90%.
Yeah, I'd agree with that. And I think sometimes you as the physiotherapist might be the one that's identifying that, so it's not being afraid to speak up, and if a patient has been deemed medically fit for discharge but you're finding they're desaturating, that you need to go back and document that, but have that conversation within your MDT, within your medical team, to make them aware of that, and have an action plan of how you're going to address it and what the treatment escalation plan would look like.
Yeah, now there's some questions about follow-up. Now I know our next speaker, Charlotte's going to touch on this, but the postcode lottery has existed before COVID in terms of respiratory follow-up. We have an excellent service, I say we in the past tense, in Lancashire, and actually across many parts of the Northwest have incredible respiratory infrastructures, which don't exist elsewhere. So that there was pre-existing pathways and pace for these patients in centres that have that ability. In other centres, they have no referral pathways. The government funding for COVID follow-up is being distributed within the local, what we call integrated care systems. So actually that should pick up some of the inequalities in terms of what people can access, whether have respiratory problems post-discharge, whether these are patients who were never in hospital, because they're the patients we don't know about, who need to then feed into a COVID clinic. And this is where we're at the moment in terms of sorting that out. Obviously now, in another wave, these services are going to be overwhelmed.
Yeah, and I think there is actually a lot of work, a lot of collaboration going on between primary care, secondary care, CCGs as well, in the commissioning and setting up of these services. And that's why the COVID oximetry service in particular has been such a success, because it has just happened. People have just got on and made it happen. And I think that is what's happening with COVID follow-up and long COVID moving forwards. But it is difficult, it is challenging.
Absolutely. Now there is some questions in the chat. I am going to answer them, and I'm sure Cath can jump on the chat if you can access it. I'm conscious that it's 3 minutes past 4 and I want to bring Charlotte in. Cath, thank you so much. As amazing as ever, and thanks for signposting us to the resources. Charlotte is our final speaker, who needs very little introduction. She has some incredible data and some incredible experience from not only the acute side of COVID, but also in terms of the longer term impacts of COVID in follow-up clinics as well. So thank you for joining me again. And sharing your experience with us. And if you don't mind sharing your screen, you can start your presentation.
Yeah, there we go. Can you see that okay?
That looks perfect. If you just want to start presenting, then it should come up big.
Yeah, great.
Brilliant, thank you.
Hi everyone, I'm Charlotte. I'm a physiotherapist. I'm based at UCLH in London. I work normally as a respiratory physio in neuromuscular diseases, but I have been involved in the post-COVID clinic at UCLH. So I'm going to talk about long COVID and kind of what it is and what we know about it so far. And I'm going to share our experiences from our clinic at UCLH, because we've seen over 1,000 patients now post-COVID. And just to touch on what Rachel and Cath were saying previously, we've seen patients who were both discharged from the hospital, both intensive care patients, ward patients, and patients using CPAP. We've also seen patients who were referred to us from ED, and we've also seen patients referred in from GP surgeries as well. So I'm sure we've all heard a lot about long COVID, and the Department of Health have come up with a kind of piece of work looking at it. And part of this is people sharing their stories. And this is one I picked out as this I thought was very typical of the sorts of patients that we've seen in the clinic. And this lady was admitted onto intensive care and been given a CPAP hood, and she thought that was kind of the worst part, and she thought once she got back home, she thought her recovery would be much easier. And actually she found that once she got home, she describes it as I thought it would be much easier compared to the nightmare I had already endured, except it was the beginning of a different kind of nightmare, long COVID. And she talks about seeing this as silent and being very debilitating with these severe symptoms. And she describes it kind of like a mountain, like that picture at the top where you have good days where you're feeling good, and then you have these dips. And this is something we've heard a lot. And I think initially, early on, people found it very difficult to access healthcare clinics and things, and kind of get the support and advice that they needed. So it's really great that there's now been so much funding put into this. And I know that lots of different centres are trying to set up these kind of post-COVID clinics. So this was the guidance I was just mentioning. This was published in September 2020. So it talks about 10% of what we would call mild COVID-19 cases, and these are people that are not admitted to hospital, have reported these symptoms lasting more than 4 weeks. And a number of hospitalised cases reported symptoms continuing for 8 or more weeks following discharge. So here's a kind of list of the persistent health problems that have been reported after COVID-19. And as you can see, they affect not just the respiratory system, but numerous other systems as well. So if we touch on the respiratory symptoms first, it's things such as a chronic cough, such as ongoing shortness of breath, lung inflammation and fibrosis, and pulmonary vascular disease. Cardiovascular symptoms such as chest tightness, acute myocarditis and heart failure. And chest tightness, I have to say, is one of the symptoms we would see frequently reported in our clinic. Inflammatory disorders such as myalgia, multisystem inflammatory syndrome, Guillain-Barré syndrome, and I'll touch a bit on Guillain-Barré syndrome a bit later when I talk about more of the neurological signs. Mental health problems, including depression, anxiety, and cognitive difficulties. Protracted loss of change of smell and taste. Some gastrointestinal problems, continuing headaches, fatigue and weakness, clotting disorders. I think you can see that it's a very, very long list there. And the aim of these post-COVID clinics is to try and pick apart these symptoms and provide the right intervention and support for these. And I've just pulled down there a table, and this was from a study group in Italy that looked at people post-COVID and during their acute phase of COVID. So these were patients who were in hospital with COVID and then were followed up after their discharge from hospital. And I think the two things we can see very strikingly there are that fatigue and dyspnea were the two biggest factors affecting people when they were in hospital, and they continued to be the biggest factors affecting people once they got home, with almost 60% of people still reporting fatigue once they were at home. The British Thoracic Society have also provided this post-COVID-19 guidance, and they suggest that a holistic assessment should be completed, which should include the following: assessment and management of breathlessness, symptom or palliative care management if required, assessment and management of oxygen requirements, consideration of rehabilitation needs and onward referral, and that's obviously a big part for us as physiotherapists, psychosocial assessment and onward referral, assessment and management of anxiety, assessment and management of dysfunctional breathing, which Cath briefly mentioned they were looking at before they were discharging patients, and I'll touch on how we assess that in our clinic. And then consideration of new diagnosis of venous thromboembolic disease. Very recently in December 2020, the NICE guidelines were developed, and this is a rapid guideline talking about managing the long-term effects of COVID-19. And they kind of split it into three groups. So you've got your acute COVID-19, which is signs and symptoms lasting up to 4 weeks. Your ongoing symptomatic COVID-19, which is signs and symptoms between 4 and 12 weeks. And this post-COVID syndrome, or what is being termed long COVID, which are signs and symptoms that develop during or after an infection consistent with COVID-19 and continue for more than 12 weeks. And I think one thing to highlight, we have seen from a lot of our referrals from GPs into our clinic, where we may have seen people in August, September, who had their COVID diagnosis in March or April, is that some people have their COVID, they have a period where they're quite unwell at home and they improve, and then they start to develop these fatigue and problems with breathlessness a bit further down the line. So this is some data that was published from the UCLH clinic a little bit earlier on in the pandemic. So this was the first 384 patients that were seen in the clinic at UCLH. They were followed up a median of 54 days after hospital discharge. So initially the clinic was set up just to assess patients that we discharged from our hospital. It has evolved over time, and we are now taking GP referrals from all over and from different areas. But this is the first 384 patients. So most of these were patients that were admitted to the hospital. So their mean age was 60 years, and they were about 62% male and 43% from the BAME communities. I think the striking figures here for me are that 69% of these patients at a median of 54 days after hospital admission were still fatigued, and 53% of these were still breathless. If we look down into the corner there, we can look at their chest x-rays. So 62% had a normal chest x-ray if their chest on review, if their chest x-ray was abnormal at discharge. 27% had a significantly improved chest x-ray. So they still had some changes, but it was much improved from their discharge date. 2% were unchanged, and 9% of patients actually showed a deterioration on imaging at follow-up than they did on discharge from the hospital. So to describe our clinic, so you can see there's a little van down there in the corner. That was where the clinic first started back in May. So patients came in, we didn't bring them into the hospital. They were seen in that little van there because we just didn't have the space. So they were assessed there. In the clinic itself is a respiratory consultant and a physiotherapist. Then we make onward referrals to other members of the MDT, and from there we can access psychology, occupational therapy, and we're also linking in very much with our community colleagues. Like I said at the beginning, we've so far seen more than 1,000 patients, and these patients are patients post-ITU, from A&E and from GP referrals, so the whole spectrum of COVID-19. This is a little analysis of our first 280 patients that were seen by physiotherapy. So we found that 20% have a breathing pattern disorder. 53% were still fatigued, which fits with the other data that we saw. And we had about 24% who desaturated on an exercise testing. To date, we've had over 100 new referrals to the UCLH Respiratory Outpatient Physiotherapy Service. So that's put a huge strain on that service, which is run by one of my colleagues. So breathlessness, we'll touch on this first as physios. This is something that we're quite keen to look at. So the most important thing is we want to rule out if there's any organic cause to explain these symptoms. So that's why it's really important that we liaise with our medical colleagues and that they are happy that there are no other organic causes causing this. So they might be things like a PE, they might be things like lung scarring, there might be some cardiac involvement, at which case those are the kinds of things that we would leave to the medical team. It's really important to get a good history of the breathlessness. So what is causing the breathlessness? Is it exertion? Is it lying flat? Is it linked to any anxiety, which is very, very common after people have had COVID? We're looking at exercise testing these patients to look for desaturations, because if there is a marked desaturation, that might show us that there may be an organic cause rather than necessarily a breathing pattern disorder. So we would do an objective assessment as you would do in a clinic. So we look at the rate, the flow, the passage of air, and the pattern of breathing. The exercise testing that we have been completing is a 1-minute sit to stand test. We are looking at pre and post heart rate, oxygen saturations, and we're asking the patients to do a Borg dyspnea scale. And we measure their oxygen saturations throughout so that we can notice if there is a desaturation during exercise and how long it takes for their sats to come back up after they stop. We can also do a 6-minute walk test, and this can be done by our respiratory physiologists if we are very concerned after them doing a 1-minute sit-to-stand test. And again, same things, they will monitor oxygen saturations throughout, and they will be asking the patient for a score of their dyspnea. So I guess in the clinic itself, what are the important things that we want to ask? So we want to ask open-ended questions. I think a big theme coming out is that a lot of these patients feel like they have not had the opportunity to talk about their symptoms. So we try to get them to explain exactly what's going on with very open-ended questions. We want to get a full history of the symptoms. So we want to find out what triggers breathlessness, what alleviates it. And we want to ask about the variability of their symptoms, their overall trend from the beginning of their COVID to now. Are they improving? Are they worsening? It's also important to get some information about their lifestyle, kind of diet, exercise, occupation, and sleep, and also pre-COVID, what were they doing before, and how does what they are able to do now compare? And also asking questions about their stress and anxiety as well. So part of our objective assessment, which I've already just touched on, is looking at their breathing pattern at rest and looking at their breathing pattern on exertion. So when we're doing the exercise test, we're also having a little look what's going on with their breathing pattern. As physio, it's important we look at their posture and check that from an MSK point of view, there's nothing else that might be affecting their breathing. Now, within our clinic, we've been using the Brompton BPAT, so the Breathing Pattern Assessment tool, which has been validated in the asthma cohort. It hasn't been validated in patients with COVID-19, but we're using it as a bit of a marker, and we're using a score of 4 or above to signal a breathing pattern disorder. Again, this is the score that is used in asthma patients. So we will do this at rest in the clinic, and then we will use this to decide whether we refer onto our respiratory outpatient service for further input regarding their breathing pattern. Now, it's important to make sure at this point that you've ruled out any other organic cause for their breathing problems. So just to briefly touch on treatment, so these are the kinds of things that we would be looking at for treatment. So looking at breathing pattern retraining at rest initially and in a supported position, and then on exertion. Thinking about postural re-education, thinking about relaxation, thinking about lifestyle management, and we have quite a lot of resources that the team have kindly put together, looking at kind of breathing pattern disorders and breathing control that patients can do. And one of the physios within our team is looking at, actually, once these patients are followed up in respiratory outpatients, what their outcomes are. We haven't quite got that information as yet because we're still ongoing with it. So fatigue. So as we saw earlier on, fatigue seems to be the most common symptom reported. And we all know fatigue is a complex medical condition characterized by long-term fatigue and other symptoms. And what we're seeing looks like a kind of post-viral fatigue, and it is affecting everybody in a different way. And I think it needs to be highlighted as physiotherapists that we're very keen to get patients back into exercise and things like that, but we really need to do a thorough assessment and link in with our occupational therapy colleagues to look at the fatigue and the fatigue management side of things. So what causes this kind of post-COVID fatigue? I guess the honest answer is we're not really sure. There's kind of many reasons why people think they might be fatigued. So a continuing response to the COVID virus, even though the infection's gone better, or just the effect of a serious illness. So it's difficult to kind of put a finger on it exactly, but there's lots of different things that contribute to the fatigue, kind of low levels of physical activity, disturbed daily routine, poor sleep, demanding work. We've had a lot of healthcare professionals who've come through our clinic who unfortunately picked up COVID whilst at work and were very keen to get back to work, and that's had quite a big impact on their fatigue. So I think Cath kind of touched on these things I guess the general recommendations for fatigue management are the same as they would be in other conditions, and thinking about, you know, rest. And I think we like to use this analogy of the fuel tank and making sure you don't run on empty. So thinking about taking short rest throughout the day, and that includes your mind as well as your physical. So, you know, making sure you're having periods where you're not looking at your phone, not looking at your computer. Trying to resume a daily routine. I'm going to touch on activity and exercise just a little bit later on, but I think the importance is slowly increasing activity and exercise, and I'll touch on that. So these are just some of the strategies that we would give to, this is a patient information sheet that we would give. So thinking about do, delay, delegate, and ditch. So, you know, what do you need to do now, and thinking about pacing. So neurological impairment. So this was brought, I've seen throughout the day, this has been brought up in terms of weakness. So is it ICU acquired weakness? Is it are there proning induced nerve injuries? At Queen Square, part of UCLH, there has been a post-COVID neuro clinic set up by some of the neurologists, because they've been seeing some increases in neurological presentation post-COVID. So lots of different things. The first article there, the emerging spectrum of COVID-19 neurology, was released earlier on in the year, and it talks about different things. So we know that due to the thromboembolic component, we're seeing more strokes. There was a query whether we would see more post-viral Guillain-Barré syndrome patients. However, a later study has said that that's probably not going to be the case. There's a study down there at the bottom that looks at mononeuritis multiplex, and how there seems to be an increase in patients with that condition after COVID. I've seen quite a few patients in my clinic who have ongoing neurological symptoms post-COVID. These might be patients that only had mild COVID, or they weren't admitted to hospital the first time. So I guess that the take-home message from this is it's not necessarily proning-induced nerve injury. They don't necessarily have a foot drop because they were prone numerous times. So it's always worth, if you're seeing somebody who's got ongoing neurological impairment, finding out whether they need to be involved with a neurologist to have ongoing tests. Other things to consider are the psychological symptoms, and these are absolutely huge. We asked patients about their anxiety and depression, and the numbers of patients that suffered with anxiety and depression was huge. So I think it's really, really important as part of your assessment to consider these things. Cath touched on it earlier, but returning to work and family responsibilities is something that patients are very, very keen to do, and also the financial implications of not being able to return to work. And returning to exercise and physical activity. And I think that during the first part, when we started in the clinic, we maybe weren't necessarily getting the right message across, and maybe we needed a bit of time to get to know the patients, to know what the right message was about physical activity. I think the thought was, once you were post-COVID, it was important to increase your activity levels and get back to normal as quickly as possible. And this has triggered some people to have some increasing fatigue, some increasing myalgia. We were working with exercise physiologists early on to try and kind of encourage exercise. And I think what we have learned throughout this is that it's very patient dependent, and there are general advice and recommendations that can be given. The biggest ones we have found is that the message of take it slow. So always pace yourself and listen to your body. You know, it's worth keeping a diary of your activity and exercise, and monitoring, you know, how you feel that day, how you feel the next day, and making sure you've got enough time to rest and recover post-COVID, because I think people were in a big rush to build back up their strength and build back up their kind of exercise tolerance, and that always wasn't necessarily the best thing. So this is our latest kind of physical activity guideline that we're using. So, you know, thinking about fatigue within that, thinking about using body weight exercises and brisk walking as a gentle exercise to build yourself back up after you have had these COVID-19 symptoms. So in conclusion, there are lots of long-term health and psychosocial effects of COVID-19. They're multifactorial. I think physios have got a big role to play in assessment and treatment. There's a high prevalence of fatigue post-COVID, and we've also noticed that breathing pattern disorders are prevalent post-COVID-19. However, it is very important to rule out other organic causes of breathlessness first before you start to treat a breathing pattern disorder. Looking for neurological impairment, so don't always assume it's ICU-acquired weakness. There might be other things going on. And return to physical activity should be a slow process, and it should very importantly take into account fatigue. And it's really important to provide a holistic approach to treatment, taking into account issues with anxiety as well. That's something that we've learned over time. So I just want to say thank you for listening. Here are my details here. And I just want to say a big thanks to Rebecca, Chrissy and Livy, who played such a huge part from a physiotherapy point of view in the UCLH post-COVID clinics. We've been trying to put together our data, so hopefully we'll have a bit more data to share with you very, very soon.
Fabulous, thank you. And you can by all means keep those couple of slides up for a little bit, Charlotte, where we'll chat. As you can imagine, the chat box is inundated now. This long COVID is a session all in itself, and we do have a couple of other podcasts on the channel if people want to learn a bit more. There's more resources out there. It's a bit confusing, some of the resources. The reality is we have a critical care patient, and we know critical care patients have complex post-critical care needs. Okay, so for the people on a basic level, we've been dealing with post-critical care syndrome, post-intensive care syndrome is what we call it, for many years. So we're trying to separate that on with Charlotte from a patient, an acute medical patient who comes in who's been really unwell, who's deconditioned and who has maybe some rehabilitation needs as well. And then we'll have the patients who have never been admitted into hospital, who go on to develop ongoing problems, maybe not even at the time of infection, maybe many months down the line. What people are trying to do is like a group anyone who's had COVID all together in where I say is a community. Not doing that, or we're saying we know what intensive care, post-intensive care looks like, and what we're trying to do is differentiate. That's why the post-discharge clinics, which yours are actually so important. But again, it's a postcode lottery. People are asking if they can refer into your clinic, but I'm presuming it's just for your locality patients.
Yeah, I think since the funding has come out for the other clinics, we were taking more referrals, but I think we're now just taking from our own area at the moment, but I can double check that.
So if you have a patient who's been in critical care because of COVID or not because of COVID, if they've been in critical care, some centres do have post-intensive care follow-up clinics. Regardless if you've had COVID or not, those patients are still being followed up in the same pathway. If you're a centre that has a critical care unit but doesn't have post-critical care follow-up clinics, then some centres have been putting something together a bit makeshift for COVID, knowing that they will likely have ongoing needs. So, and then you have the centres who just have nothing at all, and the referral is back into primary care. But like Charlotte said, these long COVID clinics could pick up those patients where there isn't a post-ICU follow-up clinic. I know it's really confusing. Just to pick up on a couple of points, I'm trying to consolidate some of them. Are you seeing a lot of like joint type pains, muscular aches? I know you mentioned this in your data for the post discharge patients.
We're seeing some, but not, I wouldn't say it's as prevalent as the fatigue or the breathlessness or the kind of anxiety element. There is some, yes, but it's not overriding, I would not say.
And we don't tend to get that with post-intensive care syndrome. But again, the long COVID patients are describing this joint pain and this pins and needles, sometimes neuropathic pain again. So again, a differentiation between two different groups of patients potentially.
I think that you make a really good point. So we've looked at our data and we've actually found that two very distinct groups between the patients who were admitted into the hospital and had quite intensive input while they were there, so patients on ITU, patients on CPAP, sometimes even the ward patients, compared to the community group that maybe came into ED or were at home and GP referrals, and the symptoms that are described are different between the groups, and the symptoms often are lasting a lot longer for the groups that the GP referral groups.
Mm-hmm. Respiratory muscle weakness always comes up. I say sometimes it's impossible because we don't routinely measure it here in the UK. So to say, do these patients get respiratory muscle weakness? I would say I don't think we measure it enough. I know you have been doing some spirometry in follow-up, and certainly we have, and there's huge variance. Some people have significantly reduced FVCs. They don't tend to have obstructive patterns. This is the fit and healthy population, but yeah, definitely some muscle weakness.
Yeah, we're not doing it on everybody, so it's difficult to say, but I guess you would expect that on a lot of post-ITU patients, so that people who've been ventilated. So yeah, it is something that is there. I wouldn't say it's not the kind of overarching issue though, the respiratory muscle weakness.
Completely agree. I mean, there's talks about should we be doing respiratory muscle training as well as rehabilitation in the acute phase. Again, I think it's not something that we would normally do here in the UK. It's a much wider conversation to happen. There's been 2 or 3 comments about pulmonary rehab and graded exercise. Now, I just want to give my 2 pence worth on this, that there again is a separation of patients here. So we know that the post-critical care patient will often benefit from structured exercise as part of their rehabilitation. But then there's another population of patients with COVID who's predominant, who might have not come through critical care, where that is absolutely not the right thing. So from my perspective, and I know that you guys have had some great results with what I would call targeted exercise therapy on an individual based assessment, but the question was, will these patients be going through a PR exercise group activity like pathway? I would say no, categorically not, because they don't fit a model like COPD patients do for PR. So what's your comments on that?
Yeah, the ones that we've referred for exercise therapy, it's been on an individual basis and they have a one-on-one assessment. So it's not a group exercise. As I said in the presentation, I think over time we've changed our thinking and our advice on it, because I think at the beginning we were maybe thinking that was the answer. And actually now we've seen more patients and we know a bit more, then no, that's not what we're recommending, no.
I completely agree. And one of the positive things about COVID is, just to try and wrap this session up, is the rapid sharing of information. And in the UK, we actually, it's recognised that our community and acute rehabilitation infrastructures are severely lacking. We've been banging on about this for years in post-intensive care rehab. And I think it just highlights the lack of infrastructure. So if we have, in an ideal world, an individual needs-based assessment for these patients, not just to go through critical care, but through respiratory medicine as well, any type of rehab, whether that be neurology, musculoskeletal, that has to be the future, doesn't it?
Yeah.
And a specific follow-up for those who have had a critical care admission. So on that note, I just want to say a massive thank you. We're only 4 minutes over. Oh. So a massive thank you for all the work and all the work that your team are doing. Now, I know you've made mention to a lot of references in your talk. They are all available online.
I've put some at the end here. That this is not everything. This is just some. There's loads more stuff out there, but this is just a handful of things if people want to look up.
In that all free access. I believe you can access them from outside of the UK as well. The NHS documents are sometimes a bit more tricky, but definitely the Lancashire Teaching Hospital document has been used, I think, in 80 countries or something. The BTS information is open access, so please do take the opportunity to just screenshot that, and you can find them in just a Google search. Thanks, Charlotte. I'm going to bring this day to a close. Massive thanks to all the speakers today, giving their time for free on a Saturday for you guys. I can't thank them enough, with what was 2 days notice, because we are super surgeon here in London and in the UK, and it was just rapid information dissemination.